Hello friends, today we are going to discuss about Autoimmune Limbic Encephalitis. I am Dr. Suresh Badadmat, Professor of Psychiatry working at NIMANS, Bangalore. In this video, I am going to discuss about Autoimmune Limbic Encephalitis, what is the etiology, how to diagnose and manage this disorder. Let's discuss about autoimmunity. As you know, in immunity, the lymphocytes play a very crucial role. The T lymphocytes directly attack the cells which are infected by either virus or bacteria and neutralizes the invading agent. Similarly, B lymphocytes, after recognizing the antigens, that is virus or the bacteria, they will release antibodies and they will neutralize them. Whereas in autoimmunity, these T cells and B cells, lymphocytes, will recognize our own cell as foreign or foreign antigen, and they produce antibodies against our own cells. They are called as autoantibodies. And sometimes T cells will directly attack our own cells. And that is called as autoimmunity. That means immunity, which is there to protect us, will act against us only. It is similar. The police is there to protect us. In certain times, the police will attack the civilian. Similarly, in autoimmunity, the immunity is required to prevent infection or else to prevent the neoplasms or tumors inside the body. But unfortunately, in certain condition, the immunity starts working against the normal cells. That is called as autoimmunity. Now, what is this autoimmune neurology? As you know, here the immunity is against neurons and neuron connecting the muscles. The most common is neuromuscular syndrome. Here, the immunity is against the neuromuscular junction, which we usually know as myasthenia gravis, which can be easily treated and the patient becomes all right within no time. Similarly, neuromyelitis optica spectrum disorder, here also the immunity is against the neuromuscular junction. And if you look at the multiple sclerosis, here the immunity is against the myelin sheath. And we know these cases very well. And similarly, paraneoplastic syndrome associated autoimmunities are well known. Here, the tumors formed inside the body, either it may be in the thymus, lungs, or maybe in the GIT, will also cross the immunity against the neurons in our brain. They are called as paraneoplastic disorder associated autoimmunity. And finally, autoimmune neuroencephalopathies are also known. So this neuroimmunology is well known and now it is a growing field. Here, especially in autoimmune neurology, the pathological antibodies that recognizes the nervous system self-antigens, that means our own nerves are being considered as foreign and certain parts of the neurons will be attacked. They may be ion channels or else the proteins of the ion channels, receptors for neurotransmitters. It can be certain parts of the neurotransmitters, neuronal intrinsic and extrinsic proteins involved in synaptic transmissions will be attacked. And these will cause various presentation in neurological conditions. And this is mainly because autoantibodies or else T cells attacking our own neurons. Advances in the medical field has been growing very fast. As you see in this chart, in 1960, there was the first antibodies targeting the striatal muscles were noted. And in the past 1 or 2 decades, there are many antibodies have been recognized. That means the advances in autoimmune neurology is occurring at the very fast rate. We are able to recognize these encephalitis and how autoimmune is playing an important role in causing these diseases. We are able to unravel those diseases and we are able to treat them. That means we are progressing at a fast rate. At the same time, we need to update our knowledge. Let's move further. What is encephalitis? because today we are going to discuss about autoimmune limbic encephalitis. Encephalitis is a debilitating neurological disorder that develops as rapidly progressive encephalopathy within a period of 6 weeks that is caused by brain inflammation. The estimated incidence is approximately 5 to 10 per lakh population. This encephalitis can be either infective or non-infective. Infective is basically either bacterial or viral or fungal infection. Non-infective can be because of autoimmunity. That means here we are going to discuss about autoimmune encephalitis. Before that, let's discuss about limbic system. Limbus means a border, the border between cerebrum and diencephalon. Limbic system is a center of emotion. Many parts of the brain have been identified as a limbic system, but there is no consensus. However, in 1937, James Papers proposed a circuit for emotions. Let's discuss that. A landmark article written by James Papers in 1937 is well known. He discussed that the center for emotion, or else James Papers circuit, consists of hypothalamus, anterior thalamic nucleus, cingulate gyrus, hippocampus, and their interconnections constitutes a harmonious mechanism which may elaborate the function of central emotion as well as participate in the emotional expression. Ladies and gentlemen, this was in 1937. But however, limbic system consists of following parts of the brain. Limbic cortex, that is cingulate gyrus and parahippocampal gyrus. Hippocampal formation, that consists of dentate gyrus, hippocampus, and subicular complex. Amygdala, septal area, mammillary body, hypothalamus, parts of the thalamus, and other parts of the brain. But however, there is no consensus on which are the parts which belongs to limbic system, because emotion is a very complex phenomena and actually the whole brain is involved. But here we are looking at which are the major parts of the brain which play a role in emotions. This is how you can see the emotions, perception of emotion, how they are perceived by the brain. You can see the various parts of the brain play a role in emotions. This is James Paper circuit of our emotions. Here you can see the hippocampus, mammillary body, thalamus, cingulate gyrus, parahippocampal gyrus, entorhinal cortex play an important role. This forms the limbic system. But now what is limbic encephalitis? That means the inflammation of limbic system. The first it was described by Berley J.B. and his colleagues. In 1960, they reported 3 patients with subacute encephalitis of adult life, mainly affecting the limbic areas. The term, the limbic encephalitis, was coined by Corliss in 1968 to describe memory loss and dementia in association with bronchial carcinoma. That means here, the first time paraneoplastic syndrome along with involvement of the brain was discussed. So what is limbic encephalitis? It is primarily defined by the subacute onset of short-term memory loss, seizures, confusion, and psychiatric system, suggesting the inflammatory changes occurring in the limbic system. That means here it is a subacute in onset. The presentation will be having memory loss, seizures, confusion, psychiatric symptoms. And let me tell you, the memory is short-term memory loss. So this is called as limbic encephalitis. Although limbic encephalitis, once considered extremely rare, associated with cancer and refractory to treatment. But however, as in the past 1 decade, it has been found autoimmune encephalitis are very common. It may or may not related to cancer, and it needs to be treated aggressively. That means limbic encephalitis has 2 important origin. One is infective. Non-infective can be autoimmune, or it can be unrelated. So that means we have to look for limbic encephalitis. Limbic encephalitis has been associated with paraneoplastic phenomena in which antibodies primarily directed to intracellular antigens of the neuron or else antigens which are on the cell surface. Sometimes this can be complement mediated immune attack also can occur. That means we are discussing about three important autoimmune limbic encephalitis. Here, one is towards the intracellular antigens, another one is surface antigens, and the third one is complement mediated immune attack. Let's move further. The current literature suggests that limbic encephalitis is not a single disorder, but it is comprised of group of autoimmune disorders predominantly affecting the limbic system. But the presentation can vary from patient to patient based upon what are the areas of the brains are affected, what is the immune response, how the immune response is acting, what is the age of the patient, whether there is a tumor, what is the etiology, what is the psychiatric symptoms, and genetic vulnerability plays a crucial role. The concept that limbic encephalitis is an inflammatory disorder, not only limited to anatomic regions of the limbic system, but also involves other parts of the brain. Not only limbic encephalitis, it also involves dorsal root gangliositis and also hippocampus, temporal lobe, brainstem, and other areas of the brain. That means although we are calling it as a limbic system, the adjacent to the limbic system, such as brainstem, temporal lobes, and other areas of the brain can also get involved. So how it is diagnosed? Let's understand. For diagnosis, limbic encephalitis can be classified into three important categories. One is classical onconeuronal antibodies. Here, the antibodies are formed against the intracellular neuronal antigens, and it is also called as paraneoplastic neurological syndromes. That means they are associated with tumors. It may be bronchial cancer, it may be small cell cancer in the lungs, or else it may be thyroid, thymoma, teratoma of the ovary, and various other cancers. The second one is antibodies against neuronal surface or synaptic antigens. This is the second one. Third one is no known antibodies are found now. They are called as seronegative limbic encephalitis. So these are the three categories we can understand and we can propagate. As I mentioned earlier, limbic encephalitis can be infective, non-infective. Non-infective, you can divide it into three. One is towards the intracellular antigens, surface antigens, and at present we don't know what antibodies are formed. Why it occurs? What is the reason for limbic encephalitis and what is the pathogenesis? Again, if you look at the limbic encephalitis, two important things plays a role. One is the environment, another one is the genetics. Let's look into this photograph. Here, the environment such as infection, gut microbiota, trauma, insult, infection can activate T cells. As I discussed earlier, the T cells will cause, again, proliferation of T cells. That means environmental can trigger the proliferation of T cells and which can attack our own cells. Further, genetic predisposition, especially polymorphism, can play a crucial role. The cytokine pathways also can activate the T cells. Once the T cells are activated, further proliferation of T cells can occur and these T cells can attack our own tissues. Further, defective regulation, that means there are some cells which is going to suppress these T cells. But unfortunately, if there is a defective regulation because of genetic reason, or else because of polymorphism, or else because of various reasons, the autoreactive T cells are not suppressed. In such a scenario also, autoimmunity can develop. Here, as I mentioned, one is antibodies against our own cells, complement mediated attack, T cell mediated attack. So these three play a crucial role in limbic encephalitis. What are the clinical features of this limbic encephalitis? First and the foremost, you need to understand autoimmune limbic encephalitis presents with subacute in onset. What is subacute? Subacute means slowly symptoms may start and it will present by the time they reach the doctor. It may be 1 to 2 months. That means over a period of 6 to 8 weeks will lapse. You need to ask the symptoms very carefully. The history taking is the crucial here. You need to ask what are the milder cognitive deficits, memory deficits, confusion, identifying people there is a problem. Those need to be asked properly. And the patient may present to psychiatrist because invariably the limbic system plays a crucial role here because the limbic systems are attacked. That means there will be emotional dysregulation. Impulsivity may be there. Since it also involves hippocampus, the memory disturbance, confusion, disorientation. Since amygdala is also involved, since it is a part of limbic system, agitation, restlessness, anxiety attacks, sleep disturbance, mammillary body is involved, irrelevant speech, catatonic symptoms can be seen. Seizures and involuntary movements also is common. Further, if it is untreated, personality changes may occur, and in acute or subacute presentation sometimes may be fulminating. That means the patient may die. Sometimes the patient also presents with depressive symptoms, irritability, hallucination, delusions. So these are the presentation of limbic encephalitis. So what are the diagnostic criteria? The first criteria which came is in Guletkin diagnostic criteria. Guletkin diagnostic criteria of limbic encephalitis talks about positive finding in neuropathological examination or presence of 4 following criteria. The following criteria are short-term memory loss, seizure or psychiatric symptoms, an interval of less than 4 years between the development of neurological symptoms and tumor diagnosis, that is cancer diagnosis, exclusion of other neurological complications, at least one of the following: CSF with inflammatory changes, MRI, especially in bilateral temporal lobe, hyperintensities are seen, EEG with epileptic or slow activities are found in temporal lobes. This was the first criteria which talked about limbic encephalitis. Further, Ross et al. Also came up with the limbic encephalitis criteria. First and the foremost, they gave importance to the onset, subacute in onset. That means it may last from 1 to 3 months, the onset period, with short-term memory loss, seizures, confusion, and psychiatric symptoms. Further, neuropathological or radiological evidences should be there, and those evidences should point towards limbic system. Further, demonstration of a cancer with 5 years of the diagnosis of neurological symptoms or the development of classical symptoms of limbic dysfunction in association with well-characterized paraneoplastic antibodies. Those antibodies are clearly given there. Or CSF pleocytosis, that means 5 cells per milliliter, or else EEG abnormalities like epileptic or slow wave activity should be seen. Further, exclusion of other etiologies of limbic dysfunction should be done. So these were the criteria proposed. Summarizing the diagnostic criteria for autoimmune limbic encephalitis. First and the foremost is good history taking to know the clinical picture. How is the onset? What is the first presenting symptoms? How it is evolving? What are the cognitive dysfunction? Whether there are seizures, whether there are abnormal movements, those need to be clarified clearly. The first and the foremost is history. Second one is demonstration of abnormalities, especially in MRI, along with EEG abnormalities and also CSF analysis. CSF analysis, along with that, we need to compare demonstration of antibodies either in serum or in cerebrospinal fluid. If it is there in both, also is well and good. EEG often shows focal or generalized slow waves or epileptic form waves can be seen. MRI findings reveals hyperintense signals of the medial temporal lobes in T2 weighted or FLAIR images. Before the diagnosis of limbic encephalitis can be determined, other causes of subacute encephalopathy should be excluded. Presence of antibodies either in the serum or CSF is not imperative. Why is this so? There are certain limbic encephalitis. At this point of time, we have not identified those autoantibodies. That means, as I mentioned earlier, some of the limbic encephalitis, we have identified those antibodies. If we are able to find those autoantibodies, excellent. Just because our science has not advanced to that level to find those autoantibodies, that does not mean if you don't find autoantibodies, limbic encephalitis is not there. That means presence of antibody is not imperative for the diagnosis of limbic encephalitis. Let's look into these important autoantibodies which have been identified at this point of time. The first one, antibodies against intracellular antigens. As you see in the first column, HU, which are involved in small cell lung carcinoma, and MA2, testicular seminoma, especially in the adults, male, GAD, thymoma and small cell lung carcinoma has been well known. And here, as I mentioned earlier, antibodies against intracellular antigens are associated with paraneoplastic syndromes. That means there is a tumor inside the body. We need to investigate. We need to thoroughly search for it. We may have to do PET scan, ultrasound, MRI scan to find the locus of origin. That means where are these tumors? And these antibodies, autoantibodies, should be looked for and also for the tumors. Moving to the second important, antibodies against synaptic receptors. Here, we know as you that NMDAR receptors, that is anti-NMDA receptor encephalitis. I'll be doing a separate video on this because here the presentation of anti-NMDA receptor encephalitis is almost most of the 70% they present to psychiatrists. Hence, I'll be doing a separate dedicated video for this. AMPA receptor encephalitis, GABA receptor encephalitis, and also dopamine 2 receptor encephalitis. Here, the main type of cancer may or may not be associated. But these antibodies, autoantibodies, have been recognized. Further, LGI1, Caspar2, DPPX encephalitis, and other autoantibodies have been recognized. And these autoantibodies, if you are able to find, the diagnosis of limbic encephalitis is well known. But however, just because you are unable to find autoantibodies doesn't mean that limbic encephalitis is not there. So let's understand what are the differential diagnoses of autoimmune limbic encephalitis. As I mentioned earlier, viral infection, that is herpes simplex viral infection, can also be presenting like limbic encephalitis. HHV6, that is human herpes virus 6 infection, systemic lupus erythematosus, Sjögren's syndrome, and antiphospholipid syndrome, primary entities of the CNS. You also need to know other differential diagnoses, such as infections of neurosyphilis, arbovirus, poliomyelitis, rabies, West Nile virus, cytomegalovirus. Further, acute demyelinating encephalomyelitis, degenerative disorders, CJDs, rapidly progressive Alzheimer's dementia, nutritional, toxic and drug-related, Wernicke's encephalopathy, alcohol-related, cocaine-related, drugs-related, chemotherapy, lithium-induced, metabolic, especially hepatic encephalopathy, renal encephalopathy, electrolyte disturbances need to be ruled out, connective tissue disorders, SLE, and various other autoimmune disorders, primary and secondary malignancies need to be ruled out. Let's look into the management of autoimmune limbic encephalitis. As I mentioned earlier, The first step is good history taking. You need to ask about minor deficits which are started maybe 2 or 3 months back. Clinical examination, look for abnormal movements, and do cognitive deficits assessment. You may need to ask for LFT, RFT, hemogram, and then MRI. EEG has to be done. Both serum and CSF testing for the most commonly identified antibodies need to be done, such as anti-LGI1, GABA-BR, AMPER, Caspar-2, and various other which antibodies, autoantibodies are known. Screening for tumors has to be done. Maybe ultrasound of the abdomen, chest X-ray, CT scan, PET scan need to be done to rule out if there are any tumors or cancers are there in the body. And here, the treatment option for limbic encephalitis largely depends upon the etiology of the disease. That means you need to find if there is any primary neoplasm is there or tumor is there and search for that aggressively and treat that. A good physical examination, CT of thorax and abdomen and pelvis, mammography of our woman, ultrasonography for the pelvis, beta HCG, AFP to screen out the testicular tumor, especially in men. And depending upon the symptoms and severity, you may have to admit the patient into ICU. But however, there is no pathognomonic symptoms to diagnose autoimmune limbic encephalitis. Because as I mentioned earlier, autoimmune limbic encephalitis is a group of disorders. It's not a single disorder. That means you have to be very careful in examining, having a high index of suspicion, good thorough history taking. Clinical examination plays a crucial role. Let's look into this flow chart. Whenever the patient presents with subacute encephalopathy, such as subacute onset of confusion, disorientation, short-term memory loss, movement disorders, seizures, psychiatric symptoms which do not qualify into any of these syndromes, irritability, anxiety, delusions, hallucinations, depressive symptoms, sometimes manic symptoms. In such a scenario, you need to do investigation suspecting limbic encephalitis. You may have to request for CT, MRI, lumbar puncture, EEG to exclude other causes. And you may have to ask for paraneoplastic antibodies, both for CSF and serum. If the antibodies to cell surface antigens are there, that means we are looking at the non-paraneoplastic limbic encephalitis. In such a scenario, we are considering the first line of treatment is steroids or immunoglobulins. Suppose if there is antibodies to the intracellular antigens are there, we are looking for paraneoplastic encephalitis. You need to look for the primary neoplasm. And you need to look for what are the treatment for neoplasms. Once the tumors are removed, what is the prognosis of the condition of the patient, depending upon that, we may have to choose the steroids or immunoglobulins. If there are no antibodies, that means at this point of time, we don't know what is the autoantibody which is causing these symptoms. That means seronegative limbic encephalitis. That doesn't mean that there is autoantibodies or not there. At this point of time, the science has not progressed to identify them. In such a scenario, we have to consider IV methylprednisolone, immunoglobulins. Let's discuss each one of them. As I mentioned, once the suspicion is there about the limbic encephalitis, you have reasonably ruled out the other causes and the differential diagnosis. Once you have done that, you need to discuss with the patient and the family members before starting the first line of immunotherapy. The first line of immunotherapy is steroids. Either you will be giving IV methylprednisolone, 100 mg IV for 5 consecutive days, or else you may give orally prednisolone. That is 1 mg per kg body weight given orally. Or else you may also consider giving immunoglobulins, IVIG. That is 0.4 gram per kg body weight for 5 consecutive days. A total dosage of 2 gram per kg body weight should be considered. However, you may also consider plasma exchange or plasmapheresis. All these three can be given in combination depending upon the severity of the illness, or else you may consider the first one, or else you may consider IV or oral depending upon the condition. At the same time, what are the resources the doctor has? where he is treating either in the primary care center or in the district hospital, medical college, or in the tertiary center. Based upon that, you may have to choose. At this point of time, there is no clear rule that you have to start steroids or immunoglobulin or plasma exchange. It is left to the presentation, and it is also the discretion of the doctor or the neurologist available. Hence, although all three are considered as the first line of treatment, based upon the presentation, severity of the condition, available resources, the neurologist will choose. If there is no response, then second line of treatment can be chosen. That is rituximab 375 mg per meter square once a week for 6 weeks to be given. It can be given alone, or else it can be considered with monthly cycle of cyclophosphamide. That is 750 mg per meter square, and IVIG 2 gram per kg can be considered. That is 8 cycles to be considered. However, please remember, there is a combination of above, or repeating the cycle based upon the response can be considered. That means, in certain time, if the patient is severely ill, you can consider first line and second line combination can be given. Or else, you have to try the first line, and if the patient does not respond, then only you have to go for the second line treatment. But however, there is no hard and fast rule, because limbic encephalitis, at this point of time, we are studying, we are examining. We do not have 100% that this patient has this autoimmune limbic encephalitis thoroughly. That means it is still evolving. Further, we need to give symptomatic treatment. Suppose the patient is having seizures, you need to start anti-epileptic drugs to control seizures. If the patient is very violent or irritable, you may have to consider psychotropic medication. But however, remember this, the patient has brain infection, or it may be paraneoplastic syndrome, or the patient has autoantibodies against limbic system. By providing psychotropic medication or antipsychotics, it may precipitate extrapyramidal symptoms, tardive dyskinesia, or NMS also can occur. Hence, you need to weigh the risk versus benefit before starting psychotropic medication. However, if the patient is very violent, refusing for treatment, trying to run away, becoming extremely suicidal, you need to give psychotropic medications. It is basically risk versus benefit. Sometimes you may also have to give benzodiazepines, but try to give short-acting benzodiazepines rather than giving long-acting benzodiazepine. But again, we need to exercise caution before we give benzodiazepine, because already the patients have cognitive deficits, especially in limbic encephalitis. Further, physiotherapy and IV fluids are required based upon the patient's condition. Now, how to assess the treatment progress? Because we have discussed about first line of treatment, second line of treatment, and also supportive treatment. When to increase and when to decrease. It is based upon the treatment progress, how the patient responds. The patient's response can be assessed based upon the modified RANKIN scale, that is MRS scale. The score of 0 is considered as no symptom at all. 1 is there are mild symptoms, but it is not coming in the way of daily duties. Second one is slight disability. Third one is moderate disability, requiring some help from the family member. 4 is moderate severe disability, unable to walk without assistance, and also unable to attend own bodily needs without assistance. 5 is severely disabled. That means somebody has to do for him. Somebody has to help him in ADL. And 6 is dead. So depending upon the scoring, you can say the patient is improving or not improving. Further, to look at the cognitive functions, you need to do serial mental status examination. That is, serial mini mental status examination. Again, depending upon the MMSE score, you can say whether the patient is doing well, not doing well. But however, one recording is not going to help. You need to do daily basis or alternate daily basis, alternate days. You need to do MMSE and MRS scoring. And based upon the scoring, you can say complete recovery if there is modified ranking scale. Rankin scale is 0, or else MMSE score is between 29-30, and this scoring is there for more than 2 months. And is completely independent of ADL. That means he's able to do his activities of daily living. The mild deficits are those where modified Rankin scale is 1 to 2 or else MMSE is more than 25. In such a case, you can consider as mild deficits and which lasts for 2 months. Anything in MRS scale score is more than 3, MMSE is less than 25, it will be considered as severe. And you need to do regular follow-up every 6 months over a period of next 5 years. Especially if the patient has paraneoplastic syndrome, you need to do follow-up very, very frequently. In certain cases, you may not find the tumor and you have not found the paraneoplastic syndrome, but however, you have missed it out during the investigation. Hence, frequent follow-up and scanning for tumors plays a very crucial role in the outcome of the disease. Hence, you need to understand, my dear friends, delay in diagnosis, severity of the symptoms, comorbid condition, infection, presence of tumor will dictate the prognosis and outcome of the patient. And the outcome, majority of the time, 70% of them do very well and they recover with mild deficits. However, in 20 to 25%, the patients will develop stable deficits. Hence, they may require neurorehabilitation. As I mentioned earlier, 5 to 10% of the patient may die. It is based upon the severity of the symptom, how the immunity is reacting, whether there is a delay in diagnosis, whether the tumor is present or not, whether the tumor can be removed or not, whether the surgery can play a crucial role, whether there is a comorbid infection, diabetes, hypertension, all these play a role in the outcome. To conclude, my dear friends, limbic encephalitis is not a single disorder, it's a group of disorder. Limbic encephalitis can be infective, that is herpes simplex virus infection, or else human herpes virus infection, or else autoimmune, that can be either paraneoplastic, that is associated with tumor, or non-paraneoplastic, that means it is not associated with tumor. And you need to investigate thoroughly. Removal of the tumor is essential. Once the tumor is removed, you can consider chemotherapy, radiotherapy, and also first line of immunosuppressant, that is methylprednisolone can be considered. And also second line of immunotherapy also considered. However, if it is a non-paraneoplastic syndrome, you may consider NMDAR encephalitis, which I'll be doing a separate video, and voltage-gated potassium channel involvement is there. If there is LGI1, that is faciobrachial dystonic seizures are present, those antibodies need to be diagnosed, and a good physical examination and observation of a faciobrachial dystonic seizure is a pathognomonic in this disorder. And also Caspar-2, that is contactin associated protein 2, which presents the peripheral abnormal movements. At the same time, the patient also will say burning sensation across the body is the commonest, as you may consider it as a polyneuropathy. So these are the presentation which occurs in autoimmune limbic encephalitis. To conclude, my dear friends, limbic encephalitis is a spectrum of autoimmune disorders. It is not a one disorder. It is a cluster of many disorders. Usually it is subacute in onset, presence of recent memory deficit, confusion, seizures, movement disorders, and or autonomic dysfunction. You can find neuronal antibodies targeting the cellular surface antigens, synaptic antigens, or intracellular antigens are well known. Here, these antibodies formed can be immunological mechanisms which are involved is the production of antibodies against these neuronal cells, receptors, or intracellular proteins. It can be complement mediated or else T-cell mediated immune response, which can cause autoimmune limbic encephalitis. However, the outcome depends upon the suspicion, early diagnosis, and treatment for a good outcome. Thank you very much for giving your valuable time. Stay safe.